Okay, good afternoon. Really great to be here to talk about asynchronous electronic communication and the provision of specialist care. My name is Clare Liddy. I'm a family doctor here in Ottawa and co-creator of the Champlain-based eConsult service.
And I'm Erin, Keely, an endocrinologist in Ottawa, and I'm the specialist lead for the eConsult program. Welcome, and we're happy to be talking to you. I'm going to have Clare start, and I'll be joining you later.
Thanks, Erin. All right, so Erin and I started this, and we're going to tell you a little bit about the history of how the service was developed in a few minutes, but I want to acknowledge all of our partners. Very much this is a collaboration between the Champlain Local Health Integration Network, the Ottawa Hospital, Briere Research Institute, and finally our service locally is still housed at Winchester District Memorial Hospital. We do have program level funding now through the Ministry of Health and also support through the Champlain Local Health Integration Network, and also a large amount of research funding through CIHR, Briere Research Institute through the Centre for Learning and Research Innovation in Long-Term Care, Canadian Foundation for Healthcare Improvement, and we've also had some great student support through Canada Health Infoway. Our third partner who's not here today is Amir Afkam, and he's the engagement and implementation lead from the Champlain LIN. Erin Keely is a specialist lead, and then as I said, I'm the primary care lead family doctor. So the module goal for this eHealth module is to introduce students to the use and impact of asynchronous electronic communication in providing specialist care and education, and we're also going to talk about the policy challenges and barriers in Canada related to this particular eHealth virtual health initiative. As I said, the overview of what we'll do really dive right into the eConsult service itself, including what was the issue that led to us developing the service. What is eConsult? We're going to give you a lot of data and description of how it's used across different specialty services, and talk also about the impact on access, cost, and patient outcomes. On the second section, we'll get into some of the regulatory and policy issues that are related to eConsult and some of the challenges and also solutions I think that we've been able to come up with our team in terms of moving eConsult across Canada. So let's start with the problem. It really is a problem of access to specialists, and I'm a family doctor here in Ottawa and did a referral several years ago actually to endocrinology, so to Dr. Keely in fact, and was told that the patient would be seen, but it wouldn't be for 6 to 9 months or so, and could I please let the patient know that that's when the appointment would be booked. At that time, as a family doctor, I was noticing increasing wait times across many different specialty services, and it was really the straw that broke the camel's back, which led Erin and I to start having a conversation and talking about and looking at different potential solutions. We know that wait times continue to remain a big problem in Canada, and what I have here are the ratings from the latest Commonwealth Fund survey. 11 countries surveyed, and patients were asked about the proportion of patients which are waiting 4 weeks or longer for specialist care, and what you can see is that Canada, unfortunately, is in last place, with 56% of people reporting that they're waiting for a specialist appointment. So clearly there's lots of room for improvement, and as I said, as a family doctor and a specialist, we knew that there were many different issues and barriers to access care along the way. So in Ontario and across Canada and many regions, you can see that the median wait time here is actually 87 days, so that's coming up to 3 months. There's a lot of challenges in scheduling appointments, challenges in terms of travel, particularly in the wintertime. Along the trajectory of people waiting for care, we know that there are duplicate testing being done, and maybe some tests that are done that are not necessary, and ultimately, in addition to the long wait time, very poorly coordinated care in some cases. So lots of room for improvement, as we said, and what we were able to develop was a eConsult service, which was really trying to harness and make the whole journey of having and getting that access to a specialist much more effective and efficient, and ultimately better for you as a patient. So what is eConsult? Very simple process. It really is an asynchronous electronic communication between providers. So between the primary care provider or nurse practitioner, family doctor, and a specialist. And it's patient specific. So an e-consult is about a patient who's in my office, somebody who's come to see me, and we really are feeling that we need to get some specialist advice. Normally I would have referred you for a face-to-face visit, which, as I've just pointed out, you probably will wait a long time, especially if it's not urgent. And instead we can do an e-consult about the question. We know that, and we'll show you the results in a minute, that we can get this much more quickly than several months. And also, we know that it may result in you not needing to have that face-to-face visit. So I, as your family doctor, can actually manage the care with the advice of a specialist. The next slide shows you a really simple snapshot look of how the service in the Champlain-Base region works. So it's very one form that you log onto, and the primary care provider goes onto a secure portal, and it's all private. It meets the patient privacy requirements. It's a secure system, and I simply sign on, and then I can initiate an e-consult. We have a drop-down menu of all sorts of different options in terms of specialty groups that you can select from. And what I do is I put the information in. I can upload an image, I can put a video on, I can attach lab results, I can use a usual referral letter, anything that I think is pertinent, and I will ask my question to the specialist. The expectation is that the specialist who the case gets assigned to will answer within 7 days. At the end of the whole case, I will be the one as the family doctor who closes off the e-consult, and I'm going to communicate whatever the results or the answer back to you as my patient, and then I'm going to complete a survey. And these survey questions, which we'll get into in a minute, has given us a lot of the data, which actually has helped us to demonstrate what the value and impact of e-consult is. So where it all started, I think I've spoken to this in terms of Champlain-Lynn. The Champlain-Lynn, for anybody who's not from Ontario, is in this little region in Ontario, so Eastern Ontario. We are a large centre, so in fact our region of 1.2 million is a larger population base than some of the eastern provinces, for example. We have one major referral centre, which is in Ottawa, and there are some rural communities which can take up to 2 hours to reach by car. The demographics here in terms of the population are very similar to the rest of Canada, and I've just pointed out again in terms of the access issues that we do have long cold winters, which are just starting here. So again, a region in Canada which, for the work that we were doing and trying to develop and demonstrate this type of a service, really was a great testing ground for the work that we've done. And what you're going to see later is that we have had quite a lot of spread and scale. So how did we go all about this, from taking that question and the issue of access, that one patient who really had some challenges getting that specialist appointment, to developing the actual e-consult service, to then testing it and doing a lot of research and development on it, which has now led us into a full sustainability and expansion mode. In brief, over the last 8 years, we did do, as I said, a lot of work at the beginning, which was really very, I'm going to restart that sentence. The development of the e-consult service has happened over the last 8 years, starting with a very small proof of concept project where we developed the system and tested it with a local group of family doctors who were actually working at Winchester District Memorial Hospital. They really helped us do the form development, which has ended up just being one form for all specialty services. And then we launched a proof of concept at that time just with 5 specialty services. The primary care providers themselves were the ones who told us which specialty services they wanted to access, in addition to what was immediately on offer, which was the endocrinology service through Dr. Keely. We did focus groups and quite a bit of qualitative work, including surveys in those early days, to make sure that the system that we developed was robust, that it was working, that it was meeting very much the needs of the patients and the providers. And in fact, early on with that work, we could see that we had landed on something that looked extremely promising. So I would say at that point, it's when we started to think about some of the sustainability elements and how could we make sure that if our early results were sustained and true, that we would be able to continue this work and not have to shut it down. We got a lot of support from our local health region, and then also applied for research grants, which we're still using and leveraging to do some of our evaluation work. And that enabled us to do a much larger pilot in the region. Subsequent to that, we did launch another pilot in the Mississauga-Halton region of Ontario, which is just outside of Toronto. At that time is when we started to create, and we were forming a collaborative with the Ministry of Health, the Ontario Telemedicine Network, Ontario MD, eHealth Ontario, and other partners, again, to be looking at this very promising model of eConsult and seeing whether or not it could be scaled and actually up across Ontario and beyond. The really great news is that with all of these collaborations and the research work that we did, we were able to create an evidence base which has very much helped drive forward the progress of eConsult across Ontario and Canada. And in 2017, we received program level funding from the Ministry of Health in Ontario to do full provincial scale and spread. So I'm going to hand over to Erin now to come back to some of our local numbers and then take you through our evidence base for eConsult. Right, over to you, Erin.
Thanks, Claire. Just move chairs here, so bear with us. So Claire's given you the story of where this started from and how we built the service, and I hope one of the things that you've heard is this was not a technology-focused service, but this was about improving access to care for patients. And really our evaluation strategy as well has focused on, is this being used for patients and what are the benefits for patients? So these are just our latest numbers, so this is up to July 31st, 2018. Looking at our regional service, the Champlain-based service. So over 40,000 people have had an eConsult sent on their behalf, and each month in our region, about between 1,100 and 1,300 people, primary care provider will reach out to a specialist through eConsult on their behalf. We have about 80% of the primary care providers in our region who have signed up for eConsult. Not all are active, but we really have had very high penetration across our primary care community. There are 114 different specialty groups, and you may think there aren't that many different types of doctors, and that's true. Many of them are subspecialists. So for instance, we have obstetrics and gynecology, but within that group we may have someone who focuses on gynae oncology, so cancer, or on menopause. So we have subspecialties. And we have all of the pediatric specialists as well, so people who are looking for advice on a child, for instance, with a heart murmur, could access a pediatric cardiologist. So who do primary care providers ask questions to? Well, dermatology continues to be the most sought after specialty, and it's remained at about 16% of all questions are asked to dermatology. Hematology, which is blood disorders, endocrinology, which I am, OB-GYN, cardiology, neurology, you can see are the top specialties requested. But look at the number of pieces on the pie. You can see that all of the specialty groups really are valuable, and this is something that we learned early. The broader the selection of specialists, the more likely the primary care provider is to use it, because they know that no matter what their question is, there will be an expert able to help them. I'm just going to give you some real-life examples of the types of questions that primary care asked and the response they got from specialists. So the primary care provider in this case, at 4:23 p.m., asked a dermatologist, this elderly patient, who you might imagine then might have trouble getting to appointments, especially in the winter, has a persistent skin lesion. A biopsy was done, so it wasn't that the primary care provider had not taken action, and it showed an actinic keratosis. So they treated this, but they didn't resolve. So their question to the dermatologist is, should I treat this for a full resolution? Should I use cryotherapy, or should I try Aldera cream? And if so, how often and for how long? So really looking for very specific guidance. The dermatologist responds just under an hour later, which is remarkable. The biopsy reported an actinic keratosis, and this rules out chondrodermatitis nodularis hellicis chronicus. I hope you don't get too swayed by that name. That may have required a reg resection. Therefore, I suggest you proceed with the cryotherapy and reassess the patient in 3 to 4 weeks. The primary care provider accepted the advice, presumably followed the advice, and closed the case. Another example from hematology, they asked the specialist about a middle-aged patient with a high B12 despite not being on a B12 supplement. Blood counts normal. What are the causes and what tests do I need to do? Notes that liver disease can cause this and recommends that the primary care provider looks at this patient's liver function. Something very much a primary care provider could do but may not have known was linked to high B12, and closes the case. In endocrinology, they seek advice on how to manage a middle-aged patient with unusually high cortisol level. The patient suffers from multiple conditions, including anxiety and chronic migraines, and is on several medications. The primary care provider gives the list of symptoms and medications. The specialist notes that one of the prescribed medications actually interferes with the blood tests and recommends an alternative method for testing. This patient would have waited in our clinic, as Claire mentioned, probably 9 months before receiving that consult to let them know that this was likely just an interference with the lab tests. This patient and their provider had their answer within a day. And then obstetrics and gynae, a bicornate uterus, and wondering about whether an IUD would be appropriate for this patient. And the specialist responded that an IUD would not be appropriate for someone with that type of uterus. And so the patient's not getting an IUD that would not have benefited them, so they could have still become pregnant, and they don't need to wait to see a gynecologist for that advice. And then a case with cardiology about whether a patient with ADHD can have a medication that may cause some cardiovascular issues. So the primary care provider provides the patient's medical history, asks the specialist if the proposed medication is safe, and whether any additional investigation should be done. The specialist is able to review the medical history that the primary care provider provided and responds there's no concerns and to go ahead and start the medication. So the medication is started potentially months earlier than it would have been otherwise. So those are some real-life examples of how primary care and specialists are interacting through the eConsult service, just to make it very real. These are patients who have been helped through the service. So how did we evaluate this? Well, we know that the only way to spread a service is to make sure that it's useful and cost-effective. The framework that we really like is the quadruple aim framework, and some of you may be familiar with the triple aim framework for healthcare improvement. The quadruple aim framework includes population health, so did it improve health outcomes, the patient experience, which is so key, so are they satisfied and did they perceive that it was a quality service, cost savings, given that it's not an unlimited amount of money that we have to spend on healthcare, it should be cost effective. But also provider experience. So do providers, given the frustrations of long wait times for their patients and the inability to access specialists, do they feel it's of added benefit? And we've been very successful. You'll see by the whiteboard behind us, that's Clare's tracking of all the papers and grants that she has on the go. And we've been very successful in being able to get this work out because people do see it as important, valuable, and worth disseminating. The data you're going to see is we are able to collect real-time usage data, how it's being used by people. We do have a closeout survey that primary care providers complete when they finish the eConsult, and we've done interviews and focus groups and other ways of collecting data as well. So this is just a summary of the evidence that we have across the 4 aims of quadruple aim, so the population health, patient experience, cost, and provider experience. And on the bottom you can see that these pillars are grounded in policy. So this is really the 5th aim, is what policies do we have, what do we need to implement, spread, and scale innovations such as ours. So let's talk about population health. So the expectation is that the specialist completes it within 7 days, but in fact the median response time is less than a day, which suggests that specialists like doing these and they're doing them in a timely way. And as the volume has gone up, this has not changed. We ask whether the primary care provider would have referred the patient for a face-to-face visit, and thus that patient would be waiting to see a specialist. In the pie graph, you can see the blue is a referral was originally contemplated but now avoided. So 40% of patients who have received an e-consult, had e-consult not been available, would have been referred for a face-to-face visit for that specialist. So we consider those avoided referrals. You'll see that 24% still need that face-to-face visit, but that action can be taken while waiting, so that medication can be started, that test can be ordered for the liver function, the biopsy can potentially be done in the office. So rather than 6 months of nothing, something is happening while the patient is waiting. And then look at the purple, the 4%. So that was a referral was not originally contemplated, but the e-consult has now prompted the primary care provider to make a referral. So that means that patient is now accessing a specialist through a face-to-face visit, where that wasn't going to happen prior to the e-consult. And in urology, for instance, that's up to 8%. And so something is making the specialist worried that they really want to see that patient, and the primary care provider is making that referral. Primary care providers consistently referred fewer patients, so primary care providers who use e-consult do not refer as many patients to specialists, and 8% of referral rate decrease in primary care providers who used e-consult. So that means that fewer referrals are being made, which means a huge cost savings to the system. So if the care can remain within primary care, that not only leads to less fragmentation, but huge cost savings. And this was based on healthcare administrative data through the ISIS. So what about the patient experience? So do patients really want not to get to see the specialist? And this type of service does not mean the specialist can't. It's an option for them, and the decision to make a referral for a face-to-face visit still resides with the patient's desire and the primary care provider. But in fact, we interviewed patients, and patients are very satisfied with receiving the advice earlier and remaining in the care of their primary care provider. So in our interviews of patients who have received an e-consult, 87% thought it was useful, 100% thought it was an acceptable way to access specialist care, and 96% consider it an acceptable alternative to a face-to-face visit. They appreciate how quick they get their answer. The primary care provider is calling them back in a couple of days with an answer for them. The care quality, and they like being able to remain within their primary care home. They have confidence in their primary care provider. They don't have to travel to see someone else. And for patients, for instance, with special needs who would be very difficult to get to a specialist appointment, it's really the only way that they may be able to access that specialist advice. So patients have commented, she took photos of both my hands, sent them through e-consult, and within 24 hours I was back in the office with a prescription. I was really, really happy, and I was so happy it was available. It gives me peace of mind. So patients are comfortable with receiving advice this way. What about provider satisfaction? Well, our providers love it. So they have a very high rate of satisfaction. Primary care providers value the quick response times, high quality advice. The answers are complete, helpful, and the educational value. And specialists like providing them. So it's a feasible way to access care. It improves communication with primary care and has educational value and is user-friendly. So one of the things that we weren't really anticipating quite as much as has happened is opening up that dialogue between primary care and specialists. Again, we used to all work in the same hospital and see each other in the hallway and be able to discuss cases and get advice that way. Those days are gone. We no longer work in the same institutions. And so primary care providers and specialists have really appreciated that opportunity to discuss cases and to receive advice and learning from each other. This qualitative analysis was done based on free text comments that primary care providers would enter when they finished the case. So voluntarily just type in comments. Lots of times it's just thank you, but there were also comments specifically around the educational value and the collegiality. So building provider relationships, it was a collegial reply. I was a new grad, it really helped me because I really wasn't sure what to do. Teaching incorporated into the answers, often the specialist will attach a document or an information sheet or attach guidelines or put in some pearls into their answer, which is really appreciated. And prompted further learning, so they told me something that I needed to learn more about, or it helped me discuss it with my other primary care docs. And as well as a specialist, the questions were so good, we're often going away and looking up the answer before we answer so that we can give a really informed opinion. So that's prompted learning for us, which is great. So thank you for the excellent teaching point. It not only prevented an unnecessary consult for this patient, but also gave me a teaching point for my future patients by avoiding unnecessary tests in asymptomatic patients with a right bundle branch block. So I can apply the information I learned in this case to the next person I see. We asked the specialists what they thought about eConsult, so we surveyed. There were 2 different services available in Ontario, so through our service, 114 specialists, the other service through Ontario Telemedicine Network, 60 specialists, and the dark blue is agree, and the green is, the dark blue is strongly agree, and the green is agree. So it prompts me to learn before I answer questions. Absolutely. eConsults are effective for providing education to primary care providers. Yes, I can teach around the case. eConsults should be used to inform CME, so we do continuing professional development, and we could use these real cases to help know what to teach in these group sessions. And it improves communication between providers. I have confidence that the primary care provider will follow through on my advice. It's important to get feedback from the primary care provider. Again, we have very limited opportunity to do that in our busy jobs, but the eConsult facilitates that communication, and we actually get feedback from the primary care provider whether it was useful or not. And I often get asked questions through eConsult that are not appropriate, and that's not happening. The primary care providers are putting a lot of thought and effort into the questions and the workup that they've already done, and the specialists are really seeing that and appreciating that, and it builds the relationship between specialty care and primary care. So from an education point of view, there is lots of learning that can happen through facilitating this communication between primary care and specialty care. So the primary care provider themselves learns something from the response they receive from the specialist. The specialist reflects on the case and has a conversation with the primary care provider, which drives their own conversation. We're creating social networks, so those communities of practice where people can learn from each other, which is replacing those hallway conversations or those medical staff meetings. And then implications for educational practice, we can use eConsult and tools like this to inform education for the broader population of primary care providers or specialists. Okay, I'm going to hand over to Clare now to finish up the other evidence for the quadruple aim.
Thank you, Erin. Right. So it's impossible to get spread and scale of a health innovation, particularly in terms of health technology, which can be quite expensive if you don't take a look at the cost. So that's what we have done, and we've looked at not only the cost of paying for the specialist, so the remuneration, but we've also looked at the cost per case and what are the potential cost savings for eConsult. So on this slide, what you see are where we're at today, which is actually fee codes that are in fact available in some of the provinces. So again, the specialist is giving advice from the beginning. We very much valued the specialist advice and felt that there should be a payment for that advice given through eConsult, even though the patient wasn't coming for a face-to-face visit. Many other provinces are moving in that direction now, and what we've done is a quick snapshot of how much an average cost per in-person visit is compared to an eConsult. So I'll just highlight that in Alberta and in Ontario there are specific fee codes, as well as in the territories and in British Columbia, which support this type of advice. Still a work in progress, but very much this type of work, and I think valuing, as I said, the specialist for the advice that they're giving, was a necessary component to ensure some sustainability in terms of this model. In Ontario, even though there is a fee code associated with it since 2012, we also, prior to that, had recommended a model which actually valued and compensated the specialist based on a time-based model, and that is the payment model that we're currently using still in the Champlain region and now in other areas of Ontario as well. So the lower cost, basically in Champlain, the specialists are paid $200 an hour, prorated to the length of time they spend completing a case, and they're able to self-select or self-report how much time they spent on it in 5-minute intervals. One of the things that we know is that in fact the average cost per case is really quite small, and it continues to be roughly $50 per case, or in many cases now even less time. So a lot of the questions that the specialist answers in fact are questions that they're very familiar with, that doesn't take them a lot of time to answer, but again, very high value for that primary care provider and their patient. Specialists don't get paid to do this if they're already on salary, or if it's considered part of their standard duty. And in other areas outside of Canada, particularly in California, which also has e-consult and e-referral, many of the specialists are doing this as part of their usual workday. The primary care providers in Ontario in particular can submit a fee code in terms of $16 per e-consult case, which really recognizes some of the additional work that goes into initiating an e-consult, and again values the fact that the primary care provider is going to be the one who's going to action the advice and continue managing their patient. If we look and do a comparison then of costs between different specialty groups, which we have done, and looked at the cost of an average e-consult case compared to a usual face-to-face visit, you see that there's a significant difference, again, in terms of the overall payment. So in this case, the study came up with an average of $47.35 per e-consult case, compared to a traditional face-to-face visit, which would have cost $133.60 per case. So again, a cost savings is incurred, which is great on the system level. We've also done and taken a look at what are the costs for patients who go to a face-to-face specialist appointment. So if you then have an e-consult appointment and you can avoid those costs, then as a person you're going to save money. So you'll save money on gas. You don't have to take the time off work. Perhaps you're a caregiver or you're going with a child. Again, you don't have to get any kind of daycare. You don't lose money by not working. So all sorts of money is directly paid by the patient, and again through e-consult we know that you will incur some cost savings and you'll save money on that. We're also interested in looking at potential savings related to what the costs of waiting are. So again, if you're on a wait list for several months, perhaps you're going to have 2 tests done that maybe weren't necessary, or you're going to be on medication that again, if there's a different recommendation and you may not need that medication if you could have an e-consult. So those are the areas where we think we're going to be able to see some cost savings. Overall, the costs of implementation, we've also looked at that, and it really is a very low-cost system, because particularly in Ontario, in both instances, the e-consult model has been built on existing technology, and really we were able to piggyback on secure private systems that were already being used for other patient health information transfer.